Varicose veins. Definition. Varicose veins are abnormally dilated and lengthened superficial veins. They should be distinguished from prominent normal veins, which are most obvious over the muscular calves of an athlete, and venous flare, the clusters of small, dilated venules that occur subcutaneously as a result of hormonal change, pregnancy or trauma. Classification. Primary or idiopathic. The great majority of cases are idiopathic. This probably represents a primary valve defect and may be familial. Women are affected twice as commonly as men. Symptoms are often accentuated by pregnancy, partly as a result of pressure of the enlarged uterus on the iliac veins and partly as a result of relaxation of smooth muscle under the influence of hormones such as progesterone. Secondary. 1. Previous deep vein thrombosis. Occluded veins may subsequently recanalize, but their valves are rendered incompetent. 2. Raised venous pressure due to compression, e.g. by a pelvic tumor, including a pregnant uterus, congenital venous malformation, e.g. Klippel-Trenaunay syndrome, arteriovenous fistula, congenital or acquired following trauma, or severe tricuspid incompetence. The last two cause pulsating varicosities. Clinical features. History. Varicose veins are prominent and unsightly, and patients may seek treatment on account of the unpleasant appearance. Other symptoms are tiredness, aching or throbbing in the legs and swelling of the ankles, particularly after long periods of standing. Other points to note are a history of deep vein thrombosis, or a history suggestive of thrombosis such as swelling and pain postoperatively, during pregnancy or after a long period of immobilization. If the deep veins are still blocked, the varicose veins that are visible may represent the sole venous drainage of the leg. A history of any complications arising from the veins, e.g. thrombophlebitis, should be sought. Examination. A patient with varicose veins must be examined while standing. Examination of the legs should include inspection of the medial gaiter area for evidence of deep venous insufficiency, hemosidrosis, eczema, lipodermatosclerosis, see later in this chapter. Overlying port wine stains or similar pigmentation may suggest underlying arteriovenous malformation, especially in young patients. Auscultation over such areas may be diagnostic. A saphenous vari, a prominent dilation of the vein, varicosity, at the saphenophemoral junction, may be present. It gives a characteristic thrill to the examining fingers when the patient coughs, quite different from a femoral hernia. It disappears when the patient lies flat. The tap test involves placing the fingers of one hand over the saphenophemoral or saphenopoppliteal junction and, with the patient standing, tapping over distally placed varicosities. In the absence of valves, there will be a continuous column of blood and a transmitted thrill will be palpated proximally. Trendelenburg's test 3 detects reflux from deep into superficial veins, and when carefully performed can identify the site of the incompetent connections. The patient lies flat and the leg is elevated to empty the superficial veins. A tourniquet is placed around the upper thigh and the patient stands up. If saphenophemoral junction incompetence is the cause of the superficial venous reflux, this high thigh tourniquet will control it and the varicose veins will remain empty. If this high tourniquet does not control the varices, the tourniquet test can be repeated with progressively lower placement of the tourniquet until the varicosities are controlled, and the level of the incompetent connection between deep and superficial veins identified. Special investigations. 1. A handheld Doppler probe is useful to diagnose reflux at saphenophemoral and saphenopoppliteal junctions. Identifying perforating veins is more difficult, and the device is not as sensitive as duplex scanning or venography. It is superior to clinical examination. 2. Duplex scanning can accurately map the veins in the leg and diagnose both valvular and perforator incompetence, as well as occlusion of large veins. Like the handheld Doppler probe, it allows accurate preoperative localization of perforating veins. 3. Venography involves placing a tourniquet around the ankle to occlude superficial veins and injecting contrast medium into the dorsum of the foot such that it will pass through the deep system up the leg. Its progress is followed on sequential X-rays. Reflux through perforating veins and deep vein occlusion are readily detected. Treatment. Indications for varicose vein treatment include the following. 1. Hemorrhage occurring from a varicosity. 2. Varicosities being grossly dilated or otherwise symptomatic. 3. Skin changes, typically in the medial gaiter area, which may suggest coincident deep venous insufficiency. 4. Incompetent perforator veins, which should be identified preoperatively to permit minimally invasive treatment. The various treatment options are as follows. 1. Graded compression stockings, indicated for minor varicosities, and for the elderly, the pregnant and the unfit. The stocking is elasticated and specially fitted to ensure that it delivers graduated compression along its length, such that at the ankle the elastic compression of the lower leg is much higher than that at the thigh. 2. Sclerotherapy. Superficial varicosities that are cosmetically undesirable may be obliterated by injection of a small volume of chemical sclerosant, e.g. sodium tetradecyl sulfate, SDS, with the vein emptied. The vein is kept compressed with firm pressure bandaging for a period of 2 weeks to enable fibrosis to take place. This outpatient treatment is used for small varices below the knee. Recurrences can be treated by further injections. Complications include bruising, phlebitis with unsightly skin staining, ulceration and deep vein thrombosis. More recently, ultrasound-guided foam sclerotherapy has become popular for treating medium-sized varices, with good long-term results. It involves mixing a sclerosant with air or another gas to produce a foam which is then injected in the affected vein. The foam does not mix or become diluted with blood, unlike traditional sclerotherapy chemicals, but remains in the vein, initiating sclerosis of the wall. It has not been properly evaluated for greater and short saphenous vein treatments. Like other minimally invasive techniques, it may be repeated to deal with recurrent or missed varices. 3. Endodermal ablation. In the last few years, endovenous treatments have become the therapy of first choice, replacing open surgery. Endodermal ablation involves passing a laser fiber along the vein under ultrasound guidance. When in position, the laser is fired and produces heat within the vein which ablates the endothelium, causing the vein to thrombose. The fiber is gradually withdrawn until all of the vein has been treated. A compression bandage or stockings are applied for 2 weeks. 4. Surgical treatments. Varicose vein surgery used to be one of the most commonly performed elective surgical procedures in the UK, and remains the gold standard treatment. Recently, the indications for the procedure have come under fresh scrutiny on account of the cosmetic nature, the need for the great saphenous vein as a conduit for future arterial surgery, such as coronary artery bypass, the cost, and the availability of good non-surgical alternatives. Surgery involves disconnecting the great saphenous vein from the femoral vein. The terminal branches of the great saphenous vein are individually ligated and divided. This may be combined with stripping of the great saphenous vein from groin to knee. If there are other incompetent communications perforators, these need to be individually ligated or avulsed. Small varicose venules can be avulsed via a small skin incision. Recurrence of varicose veins after operation is due to either a failure in the original diagnosis, e.g. underlying deep vein incompetence or arteriovenous fistula, or a defect in operative technique, particularly a failure to divide and excise all the groin tributaries of the saphenous vein. If this error is made, these tributaries will dilate and form new varices. Recurrence may also be due to the development of further varices de novo, despite an adequate operation. Complications of varicose veins. 1. Hemorrhage. This is usually due to minor trauma to a dilated vein. The bleeding is profuse owing to the high pressure within the incompetent vein. The treatment is very simple. The patient is laid recumbent with the leg elevated and a pressure bandage is applied. Subsequent to the emergency, the varicose veins should be treated by operation. 2. Phlebitis. This may occur spontaneously or may be secondary to trauma to the leg or the sclerosant used in the injection treatment of varicose veins. The varicose vein becomes extremely tender and hard and the overlying skin may be inflamed. The patient may have a constitutional disturbance with pyrexia and malaise. Secondary bacterial infection may occasionally complicate the thrombosis. Treatment: bed rest with the foot of the bed elevated and a pressure bandage on the leg, which compresses the superficial veins and increases the speed of flow of blood in the deep veins. If infection is present, antibiotics may be necessary, but this is unusual. In severe cases, systemic anticoagulation may alleviate pain and prevent spread of the condition. Non-steroidal anti-inflammatory drugs may give relief of symptoms, but they can cause peptic ulceration.